Welcome. Hello, good morning. Can everyone hear me? Can you guys hear me? Can you hear me in the back? Okay. So welcome to the Laura Mann Integrative lecture series and to Family Medicine Grand Rounds. This lecture series is part of the University of Vermont's Integrative Healthcare Initiative, which is a joint endeavor by the University of Vermont Medical Center, the UVM College of Nursing and Health Sciences, the College of Medicine, and the Laura Mann Center. The initiative's goal is to provide a holistic approach to health and wellness for optimal patient satisfaction and quality of life. So before I introduce our speaker, I just have a couple announcements. There's going to be a breakfast in the concourse here immediately following the lecture. And then following that, there's going to be a Q&A with Dr. Rakel and primary care providers in the Larner classroom. And where's Kara? Kara Feldman-Hunt is back there, so she's going to be available throughout the day and via email in the future to talk about and give us information about more educational opportunities through the program in integrative health. So it's my pleasure today to introduce our fall 2016 Laura Mann Integrative Healthcare Visiting Professor, Dr. Dave Rakel. Dr. Rakel's professional passion is to explore complex systems and to develop insight into how each can find a path towards health, which is a focus that has served in addressing clinician burnout and in strategizing to improve healthcare delivery systems. He's received funding from the National Institutes of Health to study the clinician effect and to incorporate healing modalities into medical school curricula. His team was awarded a contract to educate clinicians in the Veterans Healthcare Administration towards a personalized, proactive, and patient-driven cultural shift in healthcare delivery. He's board certified in family and integrative medicine. Dr. Rakel completed a residential fellowship in integrative medicine at the University of Arizona Health Sciences Center following 5 years in rural practice. He founded and directed the University of Wisconsin Integrative Medicine program, and he currently, as of a couple weeks ago, serves as professor and chair of the Department of Family and Community Medicine at the University of New Mexico in Albuquerque. Dr. Rakel is an exceptional educator. His academic contributions are many, including textbooks, online educational materials, which I use almost daily, lectures, online teaching videos, and these are to name just a few. So I'll conclude by saying that Dr. Rakel and Dr. Rakel's contributions have really helped shape the art, the science, and really the soul of the field of integrative medicine. So please help me in extending a warm welcome.
Good morning. How's everybody? It's good to be here in Vermont. It's beautiful. I was telling Kara I want to just grab a bike and go for a ride, but we have duties to do. So what I'd love to do with you all is to just explore how collectively we can improve the health of complex systems. We're complex systems. And I'd like to just give you a little bit of history of me before we get started. I'm sorry, I forgot to put my objectives on here. Our objectives are to be happy and doing good work for others. That's my main objective for our time together. I make money as the editor-in-chief for Primary Care Practice Update, and I co-edit the textbook of family medicine. And I'm the editor of Integrative Medicine. I make money a little bit through the sales of those books. How many people have bought a textbook recently? Really? It's a dying business. But I have no financial disclosure to any product other than educational materials. And my history is one of starting out as a family doc. Anybody been to Driggs, Idaho? Ah, very good. What were you doing there? Living. Have we met before? On the road, very good. Beautiful spot. This, when I got done with my family medicine residency, my wife and I wanted to go to a rural mountain place, and we opened up the atlas, and we thought, well, those mountains look nice. And there was one overworked doctor there who was desperately in need of a partner, and I signed up, and we practiced womb-to-tomb medicine for 5 years. And The thing that got me interested in integrative medicine, or as we hope to say, just good medicine, were the stories from our patients, right? The context of their lives. And when you're a small town doc, you know, the going joke in our town was you didn't need to use the blinker on your car because everybody already knew where you were going. It was true. That once you start to be invited into people's lives, you start to realize that just adding one drug after another is not the most efficient way of really facilitating the best possible outcome for that human being. And my neighbor, his name was Mr. Henry. He was a beautiful example of the worst arthritis you'd ever seen. He was kyphotic, he had to walk with a cane, and he didn't have any pain at all. Or at least he didn't complain of any. Unfortunately, he had a stroke, a very severe stroke that was going to take his life, and it affected his phrenic nerve, and he had these intractable hiccups. And his family was getting so frustrated because he couldn't sleep, he couldn't rest because of these hiccups. So I looked up in current literature how to best treat hiccups, and I gave him Thorazine and Haldol, and I did a great job of sedating him, but he was still, and he could not spend quality time with his family before his passing. So his family said, how about acupuncture? And I kind of giggled, really? Thorazine isn't doing it. You think acupuncture is going to do this for this guy? And I kind of giggled and I said, okay, let's ask our acupuncturist. We had one in town. And he came and he needled him and his hiccups went away and he was able to pass with conscious awareness with the people he loved all around him. And then I said, boy, I got a lot more to learn. But it's not just about the therapies that we don't consider part of our healthcare system, it's the process. And that's what I want to talk about, is the importance of the circular process in the work that we do and how we deliver it. So this is our mantra for the morning: that to which we give attention grows. If you want to be a good father or a good mother, you have to give your kids attention. If you want to be a good doctor, you have to learn the art. If you want to build your bicep, you got to give it your attention. You got to do those curls. Everything relates to this. What we choose to give our attention to grows. Are we choosing to give our attention to the right things? So this is what we're trying to do, and we all know that this is around the corner because Medicare and Medicaid are saying, we don't want to pay you for what you do, we want to pay you for the quality of the outcomes of what you do. Volume will be rewarded less, value will be rewarded more. Value over volume. That's the world that we're going to live in, and that's why primary care and relationships are so important. So there's a difference between pathogenesis and salutogenesis. Have you heard of the word salutogenesis? It's been around since the 1950s. Salud, health, genesis, the creation of. Pathos, to suffer, genesis of suffering, pathogenesis. 90% of our education is on pathogenesis. In the future, we have to get better at salutogenesis. This is the healthcare delivery system of the future, at least in America. And in order to do salutogenesis well, we have to turn towards complexity. We have to turn towards suffering. We have to turn towards emotions. We have to recognize spiritual connection. These things that are not linear is how we do value-based care better. So if I'm going to focus on salutogenesis, I have to realize the complexity of every living thing that lets that tree bloom. That's different than just treating the branch of the tree. Both are really important. But I would argue that our previous healthcare system is a little passive, that the patient is just a recipient of things. Whether it's a drug or an acupuncture needle, those are passive treatments. In order to do health outcomes better, we need more active participation from the people we're trying to help. We need their input. How can we encourage their self-reflection towards improving what they do? Because what you do is much more important in determining health outcomes than what you take. Let me repeat that. And the evidence is overwhelmingly positive for this. What we do is by far more important than what we take. Both are important. But this is what matters most in improving health outcomes. So let's explore this, because we've all been conditioned, we've all been educated in a certain way. And that influences our perception of how we see the world. And that is just reality. We're all biased. But the challenge is recognizing our bias. And I'll be frank with you, I don't like these terms. I really don't. They just invite bias. You know, what do you think of it? I got a patient, they're interested in alternative therapies. What's your perception? Right there. Oh, you gotta be kidding me. Does that mean they're not gonna do what I tell them? It's just gonna take 30 minutes instead of 15. So this really doesn't help us. We just want to do the science and understand what works and what doesn't, how we can match that science to the patient's culture and belief system. Then it's going to have a better outcome. It's not just about the science of the therapy, it's the process of how we apply the science to the better outcome of that human being. And that does not need these descriptions. So I really don't. I have owned the label of integrative medicine expert for a long time. I'm happy to let that go. I just want to be a good doc of benefit to human beings. That's our main goal. So a lot of this is about unconscious bias. And a lot of what we're trying to teach our medical students is to realize we're all biased. That's human beings. But the key is to recognize your biases. And then if I recognize my bias, it goes from unconscious to conscious, and then I know not to project my belief inappropriately on other human beings at the wrong time. First listen, then apply the best science in service of the best outcome of that human being. And that requires relationship. So all the fun studies were done before the IRB was established. This is one of those, 1973. This was a study in California where they took 8, quote, sane people, 4 psychologists, 1 psychiatrist, a pediatrician, a painter, a homemaker. 1973, that's not politically correct now, but that's how they described it in the paper. And they had them go to 8 different psychiatric hospitals with the presenting complaint of I'm hearing thuds. Okay? So you're a doctor or a nurse or counselor at that hospital. Someone comes in, I'm hearing thuds. All right, you got a bed. After they were admitted, again, they acted as sane as they possibly could. And the researchers wanted to know what diagnoses they would be given and how long they'd have to stay in the hospital. Okay? 8, whatever sanity is, sane people went into the hospital, I'm hearing thuds. After they're in the hospital, they acted as normal as they possibly could. Guess what diagnosis they were all given? Yes. In remission. Good thing you came to our hospital. We're now put you in remission. But that makes sense, right? I was trained to hear a presenting complaint and then attach a disease to it, that then I can attach a drug to it. It's a very linear process, how I was trained. It's important that I realize how I was trained and how that influences how I see people. Because it might get in the way of authenticity. It might get in the way of making the true diagnosis. They weren't really schizophrenic. Guess what the average length of stay was for these 8 people? Any ideas? Yeah, pretty close. 19 days. One of these poor souls was in there for 52 days. 52 days. Now, the interesting thing, if you read this paper, was it wasn't the doctors or nurses. I would have done the same thing because that's the way I was trained. That's acceptable treatment in my culture of medicine. I would have done it. But guess who was able to detect their authentic diagnosis? The painter, the artist. Yeah, there might be some truth to that. But they were one of the patients. But I think I heard it. The patients. The other people admitted to the hospital. Why? They went to counseling with them, they ate with them, they exercised with them, they formed a relationship with them beyond these preconditioned labels. They said, I don't think you should be here, you know? You're not like the rest of us. Isn't that fascinating? It was the schizophrenics who made the accurate diagnosis, not the doctors and the nurses. Right? I love this study. It's human nature. It's how we see the world. And the most important thing is to recognize how I've been conditioned so I don't see life as it is, or so, excuse me, I don't see life as I am, I see life as it is. And that's the key. So, let's have a little fun here. I want you to read this. You don't have to say it out loud because it might be a little embarrassing. At least it was for me the first time I did it. Just count how many F's there are in this paragraph to yourself. Don't count the F up there. Okay, do it relatively quickly. I got 3 the first time I did this. Yeah, there's 6. But we don't always see all of them. Finished files are the result of years of scientific study combined with the experience of years. Why don't we always see the F's and the of? Yes, minor consonants, unimportant. We skip right over it. Good. As with most research, that doesn't support my hypothesis, so I'm going to keep searching. All right. Other ideas? Yes, the sound. I heard it. Didn't you? How do we, in an English language, how do we say of? How would you spell it the way we say it? O-V. So we don't always see the F because we haven't been culturally conditioned to see life that way. Fascinating research in this, that our preconditioned neuroplasticity actually influences how we physically see the world. Actually changes how we see colors even. Look into this research. It's just fascinating. It's so humbling about the complexity of what it means to be human. So let's look and see how our perception has changed in a lot of other fields. How about art? This is an old painting. What's your impression of that? Is it missing something? It's kind of two-dimensional, isn't it? It doesn't have much depth. But that's all we knew at the time. This was a long time ago. The subjects are the same, human beings, but how we perceive them is differently. It's evolved over time. I would argue that healthcare delivery is still in this two-dimensional realm. But in the Renaissance, Leonardo da Vinci, they started to portray authenticity with that centering point that provided dimension and depth to paintings. And that was a tremendous evolution in art at the time. And we got better at really recognizing what's really going on in life. Authenticity. I would argue that we are still back here. We need to get to here and beyond, because our healthcare delivery has really recognized more of a linear process. And this comes from David Kopacz. He's a colleague I've worked at with the VA. He's a psychiatrist in Seattle. And I adapted this a little bit from his talk he gave on linear versus circular healing, which I really resonated with. And he makes this delineation, that in our healthcare delivery system, it's fairly linear. It's a pathological process, whereas circular healing is more of a natural process. Linear is treatment, circular is transformation. Linear is restoring old state, circular is achieving a new state. This is a key one. I learned this key point from a psychologist colleague of mine, that patients always want to get, if I'm Dave A and I go through a very serious diagnosis and that makes me Dave B, everybody always wants to get back to Dave A, right? What can you do to get me back to Dave A? It's impossible. I've experienced a serious disease. I'll never get back to Dave A. But maybe I can get to Dave C in a way that I'm wiser, I've learned, I've self-reflected, and I've really turned towards what's important in my life, and that disease has been a beautiful educator. Maybe not beautiful, but it's been an educator that allows me to realize that I'm a new person in a different state that's different from before. Volume and value, you're going to hear that a lot in the future. You are now. Hierarchical and collaborative. Circular is more shared decision making. A dependency, I become dependent on you for my health. We don't want that. It makes me feel good. Oh, Dave, I really need you to be healthy. No, you don't. I'm your partner in this process, and my job is to help you need me less. Really, our goal is for us to need less things. And then we're facilitating health transition, transformation to a better outcome. Dependency and empowerment, passive, active, concrete, and context. I think this is the most important word of really doing value and outcomes-based care better, is how do we attach this to the context of someone's life. All right, let's take an example. My bias is I have a pet peeve of just shutting off the acid pump forever. This is very linear. You come in, you've got epigastric pain, I can get you in and out of my office like that. It's accepted by my medical culture if I just turn off your acid pump. It makes you feel better, you're happy. But what are the long-term consequences of that? Why did nature give us acid? Just to be turned off? And I don't know if you follow the literature, but it's just every week the research is showing the harm of chronically shutting off the acid pump, associated with double the risk of heart disease, increases the risk of chronic kidney disease, increases the risk of memory loss, increases B12 malabsorption, iron malabsorption. All those things that acid need to help maintain the health of the body. So that's linear. It's easy, it's efficient, it's accepted by my medical culture, but I would argue it prevents us from really getting at the root of what the body needs to be well. So circular might be listening to metaphor. Hey, what's eating you up inside? That takes a little longer. When I was a resident, we had more time with patients, and I had a great story of metaphor I'll never forget. I'm going to share it with you. I had a patient come in with proctalgia fugax. That's painful rectal spasms. Periodically, it feels like someone has a knife in your rectum that's twisting. It hurts, yes, thank you. It's really uncomfortable. We usually treat it with topical nitroglycerin or a calcium channel blocker or diazepam to relax the muscle. And I was getting ready to prescribe some of those symptom masking therapies when she told me, you know what, Dave? My son is being a pain in the ass. Well, wait a second here. You're having painful rectal spasms and your son is a pain in the ass. And she said, huh. And we explored it. We turned towards suffering, right? Who wants to turn towards suffering, particularly in a 15-minute office visit? Nobody. But it's only until we stop, we pause, we turn towards suffering, that subconscious stressor that's being brought out through her rectal spasms, not all the time, but sometimes. We talked about it. We dealt with it. I got her in to see our counselor. They dealt with the issues that were going on in her family. And guess what happened? It went away. It doesn't always happen that way. It doesn't. It's complex. But when it does, it allows us to appreciate the tremendous ability of the body to self-heal if we create an environment for it to do so. That's much different than just shutting off the acid pump. Healing is circular. Biomedical model is often linear. So how well have we gotten treating low back pain? This is in one of our journals of family medicine. This is from 1999 to 2009, 10 years of data from Medicare. We've increased steroid injections over 600%, opioid expenditures 400%, lumbar MRI 300%, increased spinal fusion rate 220%, but that hasn't really improved outcomes at all. That's a lot of money going towards treatments that don't really work that well. So, why do people use CAM therapies? Pain, suffering is one of the main ones. Back pain. Let's look at back pain. How many of us love back pain? Some of us, I hope, do. But it's hard to fix, right? All right, let's kind of just explore our own unconscious bias here. I'm going to show you two different therapies, and you're going to vote on which one you would prescribe for your mom. The first one, a 12-month multi-center randomized study, 228 patients with sciatica, treatment A versus saline injection. There was transient benefit at 3 weeks for this treatment. There was transient benefit for saline at 12 weeks. There was no benefit at 6, 12, 26, or 52 weeks. The cost per quality adjusted life year, that means how much did it cost and how much did it improve that person's quality of life, was $319,000. Not good value-based care. It failed the NICE threshold. So the NICE threshold, for those who are not familiar, National Institute of Clinical Excellence in Great Britain, it's a Cochrane-like committee that says, should we sponsor this therapy? They do not sponsor this therapy. Another treatment, twice as long, 2 years, multi-center randomized open study, 241 patients with persistent low back pain, treatment B versus usual care by, I hate it when they use us as the control group. I hate that. But that's what it was. And there was a little bit of, not a lot, 10 to 15% improvement with treatment B at 12 and 24 months. And this treatment had a persistent effect after the treatment was over. The cost per quality adjusted life year was $8,000. It passed the NICE threshold, and this is a recommended therapy for low back pain in Europe, in Great Britain. Both these therapies include poking someone with something. Let's review. Evidence of benefit. Treatment B had a little bit better evidence. Cost per quality adjusted life year. Treatment A costs a lot more. Patient cost. One's covered by insurance, one isn't. So the patient's out-of-pocket cost is much greater for treatment B. One's offered in our hospital. Our hospital makes a lot of money on this. I haven't gotten fired yet for saying these things. But that makes a difference. Potential harm. Treatment A is more invasive than treatment B. Practice. What do we do in our American culture of healthcare? We do a lot more treatment A than treatment B. Which would you recommend to your mom? Treatment A? Treatment B? Oh, I was doing grand rounds for our orthopedics department on pain, and I showed a study of spinal manipulation versus NSAIDs, and the spinal manipulation worked a lot better. And I said, which one would you recommend, NSAIDs or spinal manipulation? And every one of them raised NSAIDs, even though the data. What is it about spinal manipulation that might work better than NSAIDs? A relationship and touch, right? Human connection, touch. That's going to make any therapy work better. So you guys made the right choice, according to the data, but maybe not according to your culture. What do you think treatment A is? Yeah, epidural steroid injections, correct. Treatment B? Acupuncture. You guys are good. Now, let's look at some of the data. These are meta-analyses, systematic reviews. This is a league table. You can see the quality of the research by the confidence interval. The wider the line and the smaller the power, the worse the study. So these aren't great studies. But they do show that acupuncture works versus no treatment. Here's acupuncture versus sham acupuncture for chronic low back pain, for bothersomeness and pain intensity. Based on sham acupuncture versus actual acupuncture that goes along the meridian, this seems to work. Now let's look at the league table for epidural steroid injections. This is for radiculopathy. You can see the quality of the studies are like, this is a good study. Confidence interval is narrow. The power is great. Better research on this. But it doesn't work long term. Works short term, but doesn't work real well long term. Here's a study published in the New England Journal of Medicine where they gave the steroid in one group and just xylocaine in the other. As you can see, it didn't matter whether you added the steroid or not. The effect was the same. Now, I still refer patients, despite the data. Remember, dogma always trumps data? That's human nature. I can't remember who said it, that culture trumps strategy eats it for lunch. That what we believe, what we've been conditioned, will always trump the data. It takes a while for us to believe the data and change our ways. I still recommend people for epidural steroids. Why do I do that? Any ideas? Yes. They may want it. Their neighbor had it. And also we have this is when I was at University of Wisconsin, 2 really good people doing epidural steroids. Kind. They didn't overblow it. They were compassionate. And it was part of my culture. So even though the data doesn't support it, I knew that through the process of care, patient wanted it, I had really good people doing it, I'm probably going to get pretty good outcomes, despite the lack of intrinsic value. That's what we do in primary care. We listen to the context of the human being, and we apply the best treatment evidence in service of that person, that community, that culture. This is a wonderful study looking at how much pain people had with discography. This used to be used to see if they would respond to back surgery. They would inject dye into the disc space, and how much pain they had was thought to correlate with how much impingement on the nerve. But this brave spinal surgeon published this study, and he said, well, the amount of impingement didn't matter as much as the emotional state of the person getting the discography. Were they depressed or anxious really was the main determinant of their pain. Hard, right? This isn't always the case, but 83% it was. This is my mom. She had a ruptured aortic aneurysm. You usually don't live through a ruptured aortic aneurysm. Luckily, they lived in Houston, 5 minutes away from the center that does the most of these surgeries in the world. And, if you looked at the evidence-based guidelines, you would say she's not going to have a good outcome. She was on the table for like 6 hours. But when my mom flipped me the bird with her pulse ox, I knew she was going to be okay. How do you put that into evidence-based guideline? No one knows my mom like I do. I have that insight into the complexity of her life. And that's why I love primary care. But it's hard to stay on time when you understand the complexity, right? It's not just as simple as just prescribing the drug. There's more to it. It's hard. It's difficult. I work as a consultant in integrative medicine. I work as a primary care doc. Being a consultant is so much easier than being a primary care doc. But I don't get the rewards of that human relationship. That's why I went into this work. That's what feeds me. That's what I want to do. Intimacy. So we don't always talk about intimacy in evidence-based medicine. I learned this from a consult group, the Napier group. They said trust equals intimacy times competency divided by degree of risk. One without the other is lost. I might have the most published breast cancer specialist on this planet, but if they can't be intimate, if they can't connect, form trusting relationship, you should go somewhere else. And the opposite is true. If you have a really kind, hugging oncologist, but they don't know their stuff, you should probably go somewhere else. And the degree of risk expands on that. But often we don't recognize the importance of intimacy, that human connection. So this is a fun study just to kind of explore this. When we connect with another human being, our oxytocin levels go up. This is actually one of the hormones we can measure to look at the strength of the therapeutic encounter. This is a study where they took, these are all men actually, and men have smaller limbic systems, so actually they're setting themselves up for less outcomes because men have smaller emotional centers than women. Sorry guys, that's just the way it is. So one group was given 40 international units of nasal oxytocin, and the other group was given saline. They then applied a cream to 2 spots on their arm, and it was the same inert placebo cream. But they said one was an anesthetic cream, and they told them that the other one was a placebo cream. They then shocked their arms. And what is oxytocin? Again, this is the love potion, right? What happens after you deliver a baby, right? I mean, think of the power of that hormone. Love. I can't say love in academia. It's not scientific enough. I have to change how I say it. We have to call it unconditional positive regard. Okay, Dave, how's that research going, right? But really, what we're talking about here is loving each other. It's unconditional positive regard. I care for you, and we're going to work together to a better place. And when we do that, oxytocin goes up, and look what happens when your oxytocin level goes up. They looked at the amount of pain perceived, and they used a Likert scale after shocking each places on the arm. On a Likert scale, the pain went down with the nasal saline, 7 points. When they got the nasal oxytocin, it went down almost 13 points. That's a 57.83 reduction in pain with the love potion, which we can build up just by forming a trusting relationship. For those educators in the room who have maybe doctors who don't do this very well and they're not trainable, give their patients a little oxytocin before they visit. Maybe that'll help. I don't know. All right. So the most effective way to positively influence the complexity of circularity is through human relationships. This is our way to find an inroads to authentic stories, context, life. Michael Ballant said it well. He said, by far the most frequent drug used in general practice was the doctor himself. It was not the bottle of medicine or the box of pills that mattered, but the way the doctor gave them to his patient or her patient. So when we teach meditation, it's really simple. It's focusing on one thing well. In mindfulness, we talk about focusing on the present moment. In pranayama yoga, we focus on the breath. In transcendental meditation, you focus on a word or a mantra. Very simple. The mind will wander. It always does. The practice is bring your focus back to your one thing. I use the word peace. If my flight got canceled and I'm stressing out, I just focus on the word peace. It works for me. Pick your own word. You can have mine, but it's better if you pick your own. But that's the practice. How often do we get behind in our patient care and I think, oh my gosh, I got 3 upset people in the waiting room. How can I get on to the next as quick as possible? I'm up in the clutter. The practice is, how do I focus on that one human being well? How do I focus on that as my number one priority? That patient is my meditative focus, my one thing, and then my clinical stool becomes my meditation cushion. So this led to our research. We got NIH funding. Bruce Barrett was our PI. Ted Kapchuk also got funded at Harvard. He looked at acupuncture and irritable bowel syndrome. And we looked at the clinician connection and the severity and duration of the common cold. Okay? Let me just summarize Kapchuk's research real quick. If the acupuncturists developed a trusting relationship before they threw the needles in, that worked much better, about 40% better, than if acupuncture came in, threw in the needles, and left. That human interaction enhanced the outcome of acupuncture for irritable bowel syndrome. We used the common cold. And we had to take acting lessons. We couldn't call it good doc, bad doc, because IRB wouldn't approve it. So we were standard and enhanced, okay? Or no doc. So someone within 48 hours of a common cold, they came in and I saw them. And before I entered the room, I pulled the card and I either got standard or enhanced. Standard, I tried not to, I'm sorry to keep picking on you. I tried not to connect, right? I tried not going to let it happen. In and out. I kind of gave you the impression of, you got a cold. What are you doing wasting my time, right? How does that make you feel? Not very good. That's what we did. Connection, we tried to stack the deck in favor of all the things the research shows influences outcomes in regards to non-specific variables. These are positive prognosis, education, empowerment, connection, empathy. Positive prognosis. Hey, you got a cold, but you eat your vegetables, you're exercising. I bet you'll get better in 4 days instead of 8 days. All right? Education. I would actually name the virus. You got rhinovirus. Ah, it makes it real. I got rhinovirus. This gives me control, right? I got rhinovirus. I can do something about it. Versus you got some viral syndrome, I don't know what you got. The research shows that when we say you got rhinovirus, they get better sooner. Empowerment. Hey, you can go home and eat your grandma's chicken noodle soup. Go keep taking deep breaths. How can I empower you to be a participant in your outcome? Connection. This is our acting lessons. Before I went in that room, I either felt connected or disconnected. That's how it went through my mind. Connected or disconnected. I'm going to tell you, I'm going to run out of time. I know I always do. Our inclusion criteria was 12 years of age, and we had a video camera in the room. And there was an African-American 12-year-old girl in her Sunday best. She was like an angel, literally. I thought, oh. And I said before going in the room, please let this be enhanced. Please let this be enhanced, please. And I opened the card, standard. And I went in. I was a good scientist. I went in. I did my thing. I was trying to disconnect, but this little 12-year-old girl could see I needed something more than she did. You could just feel the force field saying, I care about you, Dave. And I went through the motions. I spent about 3 minutes with her. I kind of gave her the, what are you doing here type of vibe. And at the very end of the appointment, we would always ask, do you have any other questions? So I did that. I said, do you have any other questions? And I still feel it. I just felt it right now. She asked me, do you have a family? Oh, 12-year-old. I said, yeah, I got a wife and 3 kids. Any other questions? And she said, no. You can tell she was dejected. And I left. I still carry that with me. Still, I just felt it. I still carry that with me. It ruined my day. It ruined my week. Not only did I not allow healing relationship to unfold, I thought, what is this 12-year-old African-American girl going to think of tall white doctors? What implant did I do to her brain that might influence her willingness to invite someone else into that special bond? It still hurts. I wrote about it. It's in PubMed. But you can't write about how you feel, right? Patients remember not what you tell them, they remember how you made them feel. That's what we remember. We need to work that into our healthcare delivery system. Oh, sorry, I forgot the last one. Empathy. Now let me define empathy. Empathy means that we felt their story. We repeat it back to them so they know we were heard, they were heard, and then we do something about it. That's different than sympathy. Sympathy means we cry together and go home. There's no action. Empathy requires action. I feel your story, and we do something about it. Okay? And then we interviewed them to say, how much empathy do you feel in that interaction with your doctor? This is an example of poor empathy. They did not repeat it back to them. They didn't totally understand the instructions.
Okay, then Lauren's going to catch you. Okay, it's called the trust fall. Okay, trust fall. Ready, set, go.
That's not what we want, right? Okay, let me just, before I'm breaking into our research to tell you this, and this is just coming out in the data, which is really interesting when we're talking about clinician burnout. Empathy and compassion are different. Empathy is linear. It means we're separate. 2 lines in parallel. I feel your suffering. I got to do something about your suffering. Oh, it's heavy, right? Compassion is circular. And when we train in compassion training, it means we are not separate. You and I are interconnected. And when I help you, I help myself. And we're in this together. And if you look at the research on that, I'm not going to show, I don't have enough time, but there's a study with fMRI imaging of the brain of empathy training and compassion training, and our affect as clinicians goes way up after compassion training, and it goes down after empathy training. So you've probably heard of empathy distress, empathy fatigue. That's correct. Compassion fatigue is not. Compassion is actually the remedy for empathy fatigue. And that's what the literature is showing. What happens when we teach our patients this? This is diabetic patients who participated in an 8-week mindfulness self-compassion training. And they had 2 rules. Number 1 is, don't be so self-critical. Do we do that in healthcare, medical students, residents? How often are you self-critical? All the time, I am too. Patients are the same way. How do they feel if I come in and say you need to eat better and lose weight? Oh, I'm not doing a good enough job. The other training was that they trained common humanity. We're not separate, we're all connected. And their change in self-compassion went way up after these 3 trainings, and their hemoglobin A1C went down by 1 point. Metformin and liraglutide together will reduce your hemoglobin A1C by about 1%. Treating patient self-compassion does the same thing. Which has less harm? It's a no-brainer, right? Why aren't we teaching this? And we need to teach this for ourselves. Yeah, that's the one. Yes, for this study. For the one where they did functional MRI, sorry, I forgot to give you the conclusion of that one. Kaninsky, I think, was the author. After compassion training, it lit up the centers associated with love and connection. For compassion training. In empathy training, it lit up the centers for pain. Isn't that fascinating? But it makes sense, right? I feel your pain. I got to do something for you. That's heavy. Why do we do that to ourselves? Empathy is really important, but it's how we apply empathy to a compassionate relationship where we're interconnected is the key. All right, there's our study. We randomized 3,000 folks to no visit, standard, or enhanced, and then we looked at their perception of empathy. Some gave us perfect empathy, others didn't. And then we washed out their nose for inflammatory cytokines, interleukin-8, and nasal neutrophils to see what their objective immune response was doing. Look at how much more immune system stimulus occurred when they perceived their interaction with their doctor as perfect in empathy. Pretty impressive. It reduced the duration of their common cold by 1.11 days, also reduced the severity if they perceived their healthcare provider as empathetic. But I want you to look at something. What about those who said, you're not so good at empathy, versus not seeing a doctor at all? If we're all burned out, the patient's going to do better staying at home eating his grandmother's chicken noodle soup than they are to come and see the doctor who's burned out and not good at making them feel human. We can also cause harm. What happens to empathy in the 4 years of medical school? These are women, these are men. Women come in generally with more empathy, but Adi Hermanti at Georgetown, he presented this at the AAMC. He said, if you wanted to turn a woman into a man, send them to medical school. That'll do it. We'll train the empathy right out of them. My golly. All right, so how do we apply this to healthcare delivery? This is the challenge. We got a $7 million contract with the VA health system to change their healthcare delivery system to one that's personalized, proactive, and patient-driven. Wonderful work. I'm so honored to be a part of this. We tried to really make it easy for the clinicians, where we ask 3 questions of the veteran. What do you want your health for? Just that question connects you to meaning. What areas do you feel you need the most help to get to your health goal? So the patient tells us what they need most. We don't project our belief onto them. We don't give them their science before listening, our science before listening to their story. Third question is, how do I use all the expertise we have in this culture to support your health goals? That changes our healthcare delivery to one that's empowering, salutogenic, circular, which involves the interaction of 2 human beings and a whole health culture. That's too quick to give a statin for a 10-year risk of 7.7%. right? It's much more than that. Thank God for those guidelines. They help us do our job better. But the patient's story always trumps the guideline. It's a guide. That's all it is. It helps us do our job better, but the culture, the story of the patient should always be the deciding factor. We have this circular process where we start at the beginning with the veteran. We're also doing this for our self-care for our residents and our medical students. What do you want to be a doctor for? Right? Connects you to meaning. Right away. Which of these 8 areas that are solid in the evidence foundation of how complex systems heal do you need to work on first? And then how can we use our care team to help you get to where you want to go? And then we start with me, what I need, get help from the professional. I create a community of salutogenesis that improves health outcomes. Why is this going to work? We don't have evidence that it's going to work. But why do I feel so passionately that this is going to work? What are we tapping into? Meaning. Meaning. This is how we define spirituality, a connection to that which gives life meaning. That is different for every one of us. But that's what influences behavior the most. That's motivational interviewing 101. How do you connect your behavior to what really matters in your life? We're trying to make this part of the medical culture. Tracy Gaudet told a story of a woman, 49 years old, who had type 2 diabetes, and she came in to see her doctor, and she felt somewhat punished, never being able to eat well enough or lose enough weight. And she recognized all the experts in the room, and she said, I don't care what my hemoglobin A1C and LDL cholesterol is. I want you to help me get to my health goal. And I've always wanted to reach the top of Mount Kilimanjaro by my 50th birthday. And the doctor said initially, hey, that's not what I'm getting judged on. I got to get your hemoglobin A1C down, right? But he was accepting. He said, okay, what do you need? You know, I'm not sure I can do it. Okay, let's bring in our psychology experts. I don't eat that well. Okay, let's bring in our nutrition experts. I'm not sure that I can do it. What do you need? I need to realize my spiritual connection. Her spiritual connection was Baptist minister. She got connected to that Baptist minister from her community, from her belief system. And by her 50th birthday, long story short, guess where she got? To the top of Mount Kilimanjaro. How did she feel? I did it. How did her health team and her primary care health clinic feel? Did you hear Betty? She made it. She made it to the top of Mount Kilimanjaro. Everybody rejoices. And guess what happened to her hemoglobin A1C? It doesn't always happen that way. That's a perfect story, right? That's what I choose to tell you. It's much more complicated than that. But that, if we can just add a little of that into our healthcare system, we're going to go a long ways. So when we look at outcomes, this knocks down all the dominoes. If I just focus on treating the numbers, that happens in isolation. How can I improve the efficiency of my work to knock down as many dominoes as possible? And I think asking people to connect to what matters to them in their life is the most efficient way of doing that. This is the one thing I'm most proud of in anything I've done in my medical profession. Do you guys, what EHR do you have here? Epic. Oh, we do too. I sat down with one of our leaders in our health system and an Epic smart person. And I said, we got to get the patient's goals in here somewhere. And we had this problem list. I look forward to the day where we no longer have a problem list, right? I mean, it's really a linear, reductionistic model. But they found a way that I can put patient's goal, and it goes automatically to the top of their health problem list. Really, it should be their health goal, but that's the best we could do. I want to climb to the top of Mount Kilimanjaro. Who sees that? Everybody. The nurse in the ER, hey, I see you want to climb to Mount Kilimanjaro. How can we help you get there? Right? Everybody becomes part of that conversation. Everyone. if they take the time to look and see what's most important to that person. Our FQHC now has, I'm so proud of this, and it was a team approach. You know those Got Milk buttons? They have buttons that say Got Goals. And they input their goals into the health record so we can really honor that circular process. All right, let's end with physics. I love physics because I can't understand it. It makes my head spin. But I like to read about it because there's a lot of smart people out there. Physics has gone linear to circular as well, to multidimensional. Newtonian physics is linear, gravity, right? I drop the apple, cause and effect, linear. Then Einstein came in and he said, hey, your perception and your perspective matters. There's this law of relativity. And that if I'm going to understand what that person needs most, I have to be relative to the context of their story. So I brought in a little politics here. We have a debate tonight, right? Full disclosure of my bias. One of the candidates I don't resonate with. But am I going to do any good to America if I just bicker about that person? If I'm really going to understand how to improve health outcomes, I have to first recognize my bias. I don't like that person. Sincerely, you are so different than me. I don't really like you. But let's say we're in the same room and it's my job, my profession to give service. I have to recognize my bias. Sorry, this might be too much disclosure here. And I have to come down and almost take my lenses off, recognize my lenses, sit in that person's seat and put their lenses on. And then see how they see the world. And then I am strategically positioned to improve health outcomes for that person, which hopefully will have a downstream effect for others. I mean, talk about leadership. I'd love to do this with leadership. Because look at how many lives that touches. When we self-reflect, we learn about our own biases, and then we use our own self-reflective process to be of service to others. That feels good. Now, take physics one step further. We have string theory and membrane theory, that we have multiple planes of reality that we have to collapse for our own personal reality. And the estimation is this many possibilities. If you think about from here on out, I've got this many possibilities to shape my reality. Right? What a powerful thing. Then we get into quantum mechanics, wave versus particle. And this has been proven. Everything in nature is both a wave and a particle. There's potential energy, and we collapse that into a particle. But can they happen at the same time? You watch Big Bang Theory? They talk about Schrodinger's cat. Is it alive or dead? We don't know until we actually observe it. Open the box. And then our observation collapses that potential energy into reality. Think about if we did that with patients. You need more drugs to get your hemoglobin A1C under control. Or I believe that we can get you off drugs. I believe that if we work on this, this, and this, we're going to work together to get you where you want to go. You might still need drugs to manage this complicated disease. But our goal is to really get healthier instead of just adding more drugs. So then we have all this. This happens with our cell phone, right? I got billions and billions of waves up here, and then my cell phone collapses those into intention. And there's a picture of my kids. Makes me feel good. You know, this gets so confusing. I figured I'll never understand it, so I might as well just be happy. But that in itself is collapsing my reality. That, just simple choice. I'm going to forgive you. I'm going to be happy. Look at the power of that. It takes all this potential and collapses it into a particle, a physical thing. And how we raise kids, how we see patients, can collapse their particle into goodness or badness. And our health system has to do a better job of stimulating ludogenic particles. Because I guarantee you, this is a lot more fun. This is a lot more fun. And the main way to do that is through a circular process. that is the next evolution of healthcare delivery, which for primary care is really exciting. But it's hard, right? I just got good at throughput model of care. I can see a lot of patients in a day. Now I got to work on quality and outcomes. So put in each canoe. But what do you want to do? It's not going to be easy. It never is. Change is always hard. There's a lot of quotes on it. But that to which we give attention grows. Thank you for that. Look, I don't. Do we have time for questions or any thoughts or comments? I know it's 9 o'clock. Please.
I'm so sorry to be the kids. I've never cried in Grand Rounds.
Thank you.
There will be time in longer for questions if people want to join us in there.
Thanks for coming early in the morning. Nice to meet you all.